Okay, good afternoon, everybody. I'm Dr. Sarah Rubesh, gynecologist at King Fahd Specialist Hospital and the Program Director of Gynecology Fellowship. I'd like to introduce my colleague, Dr. Sarah Nasser. She's gynecologist from Charity Hospital in Germany, and she is the COO and the co-founder of Pan-Arab Research Society of Gynecology. Today we are going to talk about the preventable cancer in women, which are the cervical cancer and breast cancer. So I'm going to talk about cervical cancer. I'm going to talk about the basic things in cervical cancer. I know our attendees, some of them are general physicians, some of them family physician. So we want to make it as simple as we can. Then follow Dr. Sarah, she's going to talk about breast cancer. As Mr. Alewa said that we leave the question till the end. We'll have 10 to 15 minutes to answer your questions. So what we know exactly about cervical cancer. So to understand cervical cancer, we have to know the anatomy, understand what are the risk factors, and figure out the symptom, do the diagnosis, and then plan the treatment of the patient. To start with, I'm going to introduce you to the anatomy of the cervix. The cervix is a cylindrical structure around 2 to 4 centimeters in length. The stromas contain fibrous and elastic tissue. It's entered to the vagina through the anterior wall, and it continued with the lower part of the uterus, and it's connected through to the uterus by what we call the isthmus. We have two openings, the external os, which is covered by squamous stratified epithelium, which is the lining of the vagina, and we have the internal os and the internal canal, and it's covered with a columnar epithelium cell. And usually, the normal process, these two cells, they are meet at the transforming zone area where we do pap smear, where we take the pap smear off. Then we have to understand what are the risk factors of cervical cancer. We have the HPV, mainly 16 and 18, and what they call it, a high risk type of HPV. And those type of HPV viruses, they have the ability to displace or disable the security program in the cell. Then they integrate themselves inside the DNA of the cell and convert the cell to precancerous and cancerous lesion. In comparison to 6 and 11, where they don't have the high affinity to displace the security system. So even if they do some damage in the cell, they don't have the ability to transform the cell to cancerous cell or precancerous lesion. In most of the reference, they mentioned that the incidence or the relation, the relation between HPV and cervical cancer, it reach up to 99%. Some reference, they mentioned it reach up to 70%. I mean, the cause of cervical cancer. The other risk factor is smoking. Smoking, it has two mechanisms to cause cervical cancer. The first mechanism is the smoking itself, it causes decrease in the function of Langerhans cell. The Langerhans cell, it is the antigen presenting cell. Usually those type of cell, they recognize the organism or the virus, then they presented their antigen to the other type of immune system. So the immune system will fight this organism and eradicate the virus from the body. But if the patient is smoke, the function of Langerhans cell is decreased. This one mechanism of involving cervical cancer, or in the mechanism, the smoking in the mechanism of cervical cancer.
سارة ممكن دكتور سارة ممكن نقرب المايك لأن الصوت منخفض بعض الناس.
طيب كده كويس؟
Excellent.
Okay, the other way of causing cervical cancer, the involvement of smoking in causing cervical cancer, that when they did a study and collect the secretion from the vagina for all smoking ladies, they found that there is a cytogenic material released from this, it's found in the vaginal secretion like nicotine and hydrocarbon. And these two material, it cause mutagenic changes in the structure of the cell. So these two mechanisms are the one which explain the effect of smoking in cervical cancer. The other cause or the other risk factor is multiple sexual partner. And it's well known because it can transmit the HPV virus. Number 4 is oral contraceptive. There is a lot of debate regarding the oral contraceptive pill. There is an international collaboration study proving that the relative risk of cervical cancer increase in the patient who use oral contraceptive pill. But does oral contraceptive pill is a co-founder? Because the patient who has multiple sexual partners, she needs to use the oral contraceptive, or by itself, it enhances the development of cervical cancer. There is no strong evidence to depend on it as it's not a cause. It's documentation-wise, it's one of the relative risk to increase the risk of cervical cancer. Number 5, exogenous and endogenous immunosuppression. Exogenous, like the patient who had a transplant, they need to be in immunosuppression. Patient with autoimmune disease, they need to be in immunosuppressive material, medication, I mean. So all these inhibit their immune system. The same thing for the patient who has HIV, so they have endogenous immunosuppression. So if we go back to all over the risk factor, we'll find that immune system plays a significant role in development of cervical cancer. Then what are the signs and the symptoms of cervical cancer? Classically, the patient will present with intermittent painless metrorrhagia, spotting post-coital, especially the patient post-menopausal come with PV bleeding. You have to consider cervical cancer and endometrial cancer as a highly suspicion or in the top of your list. Late symptoms, it is caused by the disease itself, because 75% of the disease is locally spread, so it can cause compression in the nerve and cause sciatic pain, and it can invade the bladder and cause hematuria, dysuria, and it can invade the rectum and cause obstruction. If the disease is extensive, to cause hydronephrosis and renal insufficiency. So how we can diagnose our patient? After the history and physical examination, we have to do pelvic exam. We have 3 common lesion, exotic lesion. This type of lesion, it's coming through the exocervix, and usually it comes like polypoid structure, very fragile, and bleed and touch. Sometimes it grows and it dilate the endocervical canal with and anatomical wise at the level of gynecologists, they call it barrel-shaped tumor. Infiltrative type, usually when you do the specular exam, you see erythema, some area of bleeding, but when you touch the cervix, you find it's hard like a rock. The ulcerative type, usually this patient will present with frequent infection and cerebral discharge, and when you do the examination, you see an ulceration in the cervix or in the vagina. Even if the lesion is clear and saying that it's me, I'm a cancer, you have to take biopsy to confirm your diagnosis and the type of the cancer. Then you have to proceed in further investigation, which is the MRI. The value of having MRI is to evaluate the extent of the disease. It's invading, as I mentioned before, if the patient presented with the late symptoms, it's invading the bladder, if it's invading the rectum, it's invading the parametrial. Then the other, the second images that you have to ask for it is the PET scan. PET scan is an image where we use the radioactive material conjoined with the glucose, and it's well known that most of the tumor cell, they consume more sugar than normal. So when you do the images, these type of cell, when they take the glucose, they will emit high radiation, and you can distinguish them from the normal cell. Here I'm just showing you the frequency of lymph node metastasis in cervical cancer, the majority in the pelvis, but doesn't mean the para-aortic lymph node are they spared. There is a chance of 27% of para-aortic lymph node involvement, and even distance metastasis reaching to scalene lymph node, which is in the left side of the clavicle. Then after you do the biopsy and the investigation, you have to stage your patient. And the objective of staging your patient for two things. The first thing is to plan your treatment, because the early stage you can go with surgical intervention. The second point is to evaluate the 5-year survival. So if the patient presented to you with an advanced stage, you know that you have to give them treatment, but you know that their survival 5-year survival rate is not high in comparison to early stage. This is the only classification or the only staging system where they use a clinical assessment to assess their patient. In 2018, figure staging was changed, and the only difference was in stage 1B, they made a difference according to the size. Why? Because some gynecologists, they don't do a surgery for their patient if it's more than 4 centimeters, because they feel that they can't remove the tumor completely with a clear margin. And the second modification they made in the figure staging is adding the lymph node involvement in stage 3C. They put stage 3C 1 and 2 for para-aortic and pelvic lymph node to plan the extent of radiation therapy. Okay, now what are the modalities for treatment? As I mentioned, if you have your patient treated, diagnosed in early stage, you will do for them either simple hysterectomy if she's stage 1A1, which is a small lesion, but if it's higher than this, you will go for radical hysterectomy. Radical hysterectomy means that you have to remove the parametria of the cervix, and the parametria is the fascia covering the cervix and extending laterally to the pelvic side wall. The other modality for treatment is giving concomitant chemoradiation. What does it mean, concomitant chemoradiation? Meaning that you give a course of radiation therapy for 6 weeks, and you give a chemotherapy single agent every week. And this recommendation based on 4 randomized control study proven that if you add a chemotherapy to the course of the radiation therapy, the response to the treatment is higher in comparison to radiotherapy only. But the patient presented to us with advanced stage 4B, those patients, we give them chemotherapy only, unless they have symptom BV bleeding, where we give them palliative radiation therapy. Now we come to our question, is cervical cancer is a preventable disease? Yeah, it's a preventable disease. They just do a pap smear for all the patients from, according to US recommendation, for all the patients from 21 until 65 years old, they have to have a pap smear every 3 years. But if she's older than 30 years old and you add HPV to your pap smear test, you can screen them every 5 years. So it's just a simple test, you can prevent cervical cancer. What the other modality of preventing cervical cancer is vaccine. We have 2 types of vaccine. Gardasia, which covering 4 types of HPV, 6, 11, 16, and 18, and Cervixa, which covers 16 and 18. Those 2 vaccines are not available in the government in Saudi Arabia, governmental hospital, but they're available in some sector, some private sector. So what are the doses and the ages of the vaccine? It should be given to the patient 3 doses. The ages for the female 13 to 26 and male from 9 to 26. But in 2018, FDA approved the Gardasil, which covering 16 and 18 and the other HPV high risk type. And they allow to take the vaccine for the patient even if she's older than or if he's older than 26 years old until the age of 45 years old. How we can give the doses. The first and the second dose should be separated by 1 month, and the second and the third doses should be separated by at least 3 months. And if there is any interruption in the vaccine, we don't have to restart it. We don't have to restart the program. We can just continue giving the vaccine course. So just a brief comment about cervical cancer in Saudi Arabia. It's the 8th most common cancer in women between 15 and 44 years old, and it's number 12 causing death among these women. And this is according to the registry 2014, and the last registry done, it was 2016 in Cancer Registry Center in Riyadh. And there is no much of difference in these numbers. And according to Saudi Ministry of Health in 2014, they estimated that the incidence of cervical cancer by 2025 is going to be 309, and death is going to be 117. And according to ECHO, it is an Spanish institution, was this institution collect information about HPV in Saudi Arabia related to different cancers, cervical, anal, and rectal, and oral. So they published their information in 2018, and they mentioned that the crude incidence of cervical cancer in Saudi Arabia is 2.2 and mortality is 1.1. By this, I'm finishing my presentation, and these are my references. And I would like to invite Dr. Sarah to start her presentation.
I will just share my screen. 1 second. Perfect. Great. Thank you very much, Dr. Sara, for this invitation, first of all, to talk about these very important subjects in women's health, particularly preventable cancers. This is actually what we do and what our job is. So thank you for the invitation. And I'm delighted to be able to cover this topic today, which is breast cancer screening, and that we are able to exchange our experiences between Germany and Saudi Arabia. So my focus is breast cancer and the screening program in breast cancer and how it's performed in Germany. In Germany, compared to other European countries, breast cancer is actually a gynecological specialty. So we train as gynecologists with breast cancer and as gyne-oncologists as well. So we have the privilege to be able to also perform the screening in this area. And so the gynecologists screen for breast cancer in Germany. So why are we talking about breast cancer? First of all, it's a common cancer. Breast cancer is diagnosed every 29 seconds around the world, and in the United States, it is every 2 minutes. So it is common. In Germany, the lifetime risk of a woman developing breast cancer is 1 in 8. So 1 woman out of every 8 will have breast cancer at some point in her life. Globally, the incidence of breast cancer is about 40 in 100,000, and the mortality is 13 in 100,000. It is the most frequent tumor affecting women worldwide. In Europe in particular, it is known to be a cancer that's affecting more the higher income countries, also because it's more typical with the Caucasian population. The incidence in Europe is slightly higher than the global incidence. It's at about 69 in 100,000, with a mortality of about 16 in 100,000. In Germany, yearly, there are 75,000 women diagnosed with breast cancer, breast cancer constitutes 1/3 of the cancers that affect women, and the 5-year overall survival rate of breast cancer in women in Germany is about 79%. The incidence in Germany is 91 in 100,000, so it's higher than the global incidence. And most likely this is because it's picked up more often due to the screening program. Also, breast cancer is expensive. It's expensive to diagnose, to treat, and the follow-up is expensive. Breast cancer is one of the top 3 cancers that cause the most economic impact in the world, with about $29 billion. This is data from 2016, but the prediction was that by 2020, there will be 1.7 million new cases of breast cancer yearly, with about 500,000 deaths caused by breast cancer each year. And breast cancer comprises 10.5% of all new cancers worldwide. So it's a common tumor, it affects women, and it is expensive to diagnose and treat. But luckily, it is curable when we pick it up in the early stages. So we can actually do something about it. This chart is from 1999, but it's actually still relevant nowadays. It shows that the bigger the tumor size at diagnosis and the more advanced the staging of the breast cancer is, the lower the overall survival rate will be. So it makes sense that if the tumor is picked up in the earlier stages, when it's smaller, the overall survival will be higher, so we can cure it. So this is why breast cancer is an important topic. It's a common tumor. It obviously does have a healthcare impact economically as well to treat and diagnose, but we can do something about it. It's preventable. And this is why we have a screening program for it. And like with any screening programs, there are 3 components to screening. Any effective screening has 3 components, and they obviously overlap. And I will start with the circle on your right, so cancer prevention. Cancer prevention, what I mean by that is all the risk factors. So any risk factors that can be identified in the population that would make a woman at higher risk of developing breast cancer in her lifetime. So this is an important aspect of screening. It starts with prevention. And we will talk about all these aspects. Then there's the breast screening. So this is the actual screening program that's used. And you have the different tools that we use for breast cancer screening. One of them is the self-examination. Then there's the clinical examination performed by the gynecologist. And then there's the mammogram, so the mammography screening program, as well as additional tools such as the ultrasound and the MRI scan. And we will talk about how these are used in Germany. And then there's the genetic screening. So the genetic screening overlaps also with cancer prevention and the risk factors. So these are the women that are at higher risk of having familial breast cancer. So breast cancer that occurs because of a genetic mutation that's carried by this woman. And these women, they don't go into the general screening program. They have a specific screening program, which is actually not called screening anymore. It's called early detection. So once a genetic mutation is identified, you have an intensified program, which involves shorter interval times where this woman gets screened in order to see if we can pick up breast cancer early. And this is the early detection program. So this is breast cancer screening in Germany. I've left this in German on purpose so that you can see that this is also what we use in Germany. And basically it starts with self-examination. So we encourage our women, our patients, to examine their own breasts, to get to know what their breasts look like normally and what they feel like. And also what they feel like at different times of their cycles, because as you know, breast tissue responds to hormones and these change over a woman's cycle. So the breast tissue will swell and will feel different at different times of the cycle. Our recommendation is that every woman, at least from the age of 30, but she can start earlier, should examine her breasts every month, once a month at least, and preferably on the 3rd day of her cycle, so where the swelling and the breast tissue are going down. And studies have shown that actually if women do that consciously and they perform self-examination, they can actually feel lumps in the breasts and nodes that are as big as 2 centimeters. And as you can remember the chart I showed you before, that the smaller the tumor when you first diagnose, the higher the chance of survival. If she doesn't self-examine, and if she picks a breast lump up incidentally, so while taking a shower or while changing, generally they're about 3 centimeters. So there is a 1 centimeter difference from the size of the breast lump that a woman can pick up if she consciously self-examines her breasts once a month. So this is the first point of breast cancer screening. The second point is the clinical examination by the gynecologist. So in Germany, the gynecologists do the breast cancer screening, and every woman goes to a gynecologist once a year. So this breast examination is done yearly. From the age of 30, the gynecologist will then also examine the woman's breast. And gynecologists tend to find lumps as small as 1 centimeter. So it's even smaller, and it's even a better detection rate. So the self-examination and the clinical examination are 2 important parts of the breast cancer screening. Then there's the mammography screening. So mammography screening in Germany was introduced in 2002. This is actually relatively late compared to other European countries where it was introduced in the 60s and 70s. But in Germany, they started in 2002 because there were some debates about radiation exposure, which we can go into later on. It's a population-based screening. So every woman will get an invite to attend the mammography screening in Germany from the age of 50 till the age of 69. And this is where really the highest evidence is that mammography screening can pick up early breast cancer. Women under the age of 50, so between the age of 40 and 49, the evidence is slightly more in the gray area that mammography actually helps in reducing the mortality from breast cancer. And this is why in Germany, the age for mammography screening starts at 50 and goes to 69. After 69, there is no data that mammography again helps to detect breast cancer. However, some women still decide to carry on with the screening. It's done every 2 years. There's no evidence that doing a mammography screening more frequently actually helps detect breast cancer earlier. So 2 years is the interval for the screening. And in Germany, it's performed in designated breast screening units. So they're distributed regionally all over Germany, and they send out the invites to all the female population that are between the age of 50 and 69. And then the women attend, they make their appointment, they attend the screening unit, and they get the mammography screening. So how does mammography work? So basically a mammogram is an X-ray image. It's an X-ray of the breast. The breast is compressed between 2 metal plates, and then there's an X-ray taken in 2 planes. And this is very good because it can show very early changes. So up to even less than 0.5 centimeters, less than half a centimeter, it can show changes in the breast tissue, and it can also show microcalcification. So it can show pre-invasive breast disease as well. And I wanted to show you here, you have an image. So you have, this is what a mammogram image, an X-ray image would look like. On the left, you have a normal breast image. And on the right, you can't see all of it because the table is in the way, but you can see that it doesn't look normal. There is an abnormal nodule there. So if this is the case, then you would carry on further investigations. So you would add an ultrasound, an MRI, and you would also biopsy the nodule. Mammograms, the results of mammograms are interpreted by using a particular radiographic score. It's called the BI-RAD score. And this is what I've shown in the table. So the score goes from 1, which is negative, which means the likelihood of this being cancer is almost 0. So they go just, it's a normal mammogram basically, all the way down to 5, which means it's highly suggestive of malignancy and definitely needs a tissue biopsy. And the likelihood of this being cancer is more than 95%. And then you have the levels in between. And obviously 0 means that something, it's not conclusive, and 6 means that actually this was already biopsied and it's a known tumor. So is a mammogram an effective screening tool? Well, for a tool to be effective at screening, it has to pick up a disease in the early stages that we can still do something about it. And we know that a mammogram can do that. It detects breast cancer in the early stages. and hence reduces mortality, but also reduces the need for radical operative therapies because we're picking up the cancer earlier, and reduces the need for systemic chemotherapies. So because we're picking up the cancer at an earlier stage, operative therapies and systemic chemotherapies may not be as necessary as if the disease was being picked up in more advanced stages. 7 in 1,000 women are diagnosed with breast cancer via the mammography screening program in Germany. Mammography screening increases the detection of early breast cancer by about 20%. I have to say that about 10% are false positive results. And this was the debate that was happening when mammography was first introduced, is that obviously you have a high rate of detection, that's correct, but you also have 10% of false positives, and that can cause a lot of anxiety with the women and unnecessary biopsies and so on and so forth. So this is a number that we need to keep in mind. The uptake for mammography in Germany is about 51%. So about half of the women that get invited actually go for the mammography screening. And this is different in other European countries. So in Denmark, for example, the uptake is much higher. It's about 80%, but they have also a different recall system. So they, in Germany, the breast screening unit, they send out an invite. And then the woman is responsible for making her own appointment at the screening unit and attending the appointment. So you can imagine that sometimes this may not happen. So the uptake rate is 50%. This is a good uptake rate, but then you have other countries that have a higher uptake rate because they then actually also call the woman via phone and ask why she hasn't attended. There is a much more intense follow-up to why women don't show up for the breast cancer screening. And as you can see, this is just, again, a reminder that the more advanced the stage of the breast cancer, the lower the survival rate. And so it makes sense that we want to pick this up at an earlier stage so that we're able to treat it and increase the survival rate. So this was breast screening, so the screening program. Now, the genetic screening. Genetic screening is also part of it. And I spoke about early detection beforehand. Screening and early detection are two slightly different things. So screening means that you perform a test on a healthy population. And you see whether this population has the disease or not. Early detection is the same test that you perform on a population that you already know has a higher risk factor for developing this disease. And this is where I want to talk to you about genetic mutations. So some risk factors for breast cancer are listed here, the common risk factors. Some of them are preventable and some of them are not preventable. So the factors that I want to talk about first are the non-preventable ones. So factors that we can't do much about. So breast cancer is known to be more common in Caucasian population, which is probably why the incidence is higher in Europe than worldwide, simply because that's where most Caucasian population is based. It's also a disease of age, so it has a higher incidence in women over 50. And obviously, if you have a genetic mutation that puts you at high risk of having breast cancer, then this is also a risk factor. All of these cannot really be prevented. The last square here also says reproductive and family history. Obviously, this is in some ways might be preventable, but not always. So you can't always plan to have a pregnancy. This may not always go as planned. So some are risk factors that are not really preventable. But I want to focus on genetic mutations. So you can't mention breast cancer and genetic mutations without showing the famous actress that did a big campaign about this, Angelina Jolie. Having said that, most breast cancers are not familial breast cancers, so they're not caused by genetic mutation. Only 5% are caused by genetic mutation. But because we can test for a genetic mutation, we can actually easily prevent breast cancer happening. And this is why it's important, because we can actually do something about it, similar as Dr. Rubesh said with cervical cancer. We can do something about it if we pick it up early. And this is why it's important, even though it's only 5% of all breast cancers. The most high-risk mutations, which are found in about 25% of genetic breast cancers, are the BRCA1, the BRCA2, and the RAD51C genes. And if you have mutations in these genes, there is a lifetime risk increases to sevenfold. So the lifetime risk of a woman is about 1 in 8. So if a woman has a BRCA1 or a BRCA2 mutation, that risk increases times 7. So it has about 70% chance of developing breast cancer by about the time she's 80 years old. There are also many other mutations that can cause an intermediately raised or low risk group. And these I've listed below. I don't need to go into all of them, but just so you have an idea that these are all mutations that are tested in these women. And obviously, if they have a relevant family history, so if they've had relatives, mothers, sisters, and so on, who have had breast cancers, that also increases the risk. So who gets tested for genetic mutations in Germany? There is specific criteria based on a family history of a person. So if there is a suspicion that this person might have genetic mutation, they go to a specific genetic counseling. And there they do a very detailed history and a pedigree for this patient, and they look at the family history. I've listed the specific criteria that if one of these criteria is present, this person will get tested for a genetic mutation that may cause breast cancer or even ovarian cancer. So as you can see here, it's a family history. I don't need to go through all of them, but there's, for example, if 3 women in the family were diagnosed with breast cancer, or if 1 woman had breast cancer on both sides, or if there's been 2 women diagnosed with ovarian cancer, for example. And also not to forget, even though it's very rare, men can also have breast cancer. The lifetime risk of a man developing breast cancer is 1 in 1,000. So it's obviously much less than for a woman, but they can still develop breast cancer. So if in the family there's a man who's developed breast cancer and a woman who's either developed breast or ovarian cancer, then this would also be a criteria to get tested for a genetic mutation. And obviously, if the woman herself has had breast cancer or has had ovarian cancer, then in Germany, this is an indication that this woman needs to get tested for genetic mutations. The testing is then done via blood. So you take a blood sample and it's a multi-panel test. So you test all the mutations that I showed you before, the high risk, the intermediate, and the low risk. And you check if any of these mutations are present in the blood. Now, if this woman has a genetic mutation, then she doesn't go into the normal screening program that I mentioned before. So the self-examination, the clinical examination, and the mammogram every 2 years, but she goes into the early detection program because we already know that this woman has a higher risk than the general population. So she needs to be intensely monitored to see if she will develop breast cancer. And so in Germany, the early detection program starts with a clinical examination at the gynecologist every 6 months from the age of 25. She also has an ultrasound every 6 months of her breasts from the age of 25 until she's 70, and then she has it every year after that. She also has an MRI from the age of 25 every year, an MRI of the breasts, and she has a mammogram from the age of 40 every year. So all these modalities together in order to pick up any sort of early changes in the breast tissue in a woman who has a genetic mutation and hence has a higher risk of developing breast cancer. Some other risk factors that I mentioned before that are independent from race, age, and genetic mutations are, for example, reproductive and family history. So one of the risk factors is early menarche, late menopause, so a higher exposure of menstrual cycles, higher exposure to estrogen in a lifetime. Late pregnancy after the age of 30 has also been known to increase the risk of breast cancer. This is a point which is slightly controversial because pregnancy as such is known to actually reduce the risk of breast cancer. But if it's a later pregnancy, so after the age of 30, this can actually increase the risk of developing breast cancer. Hormone replacement therapy. Now, this has been a controversial topic for many years, whether hormone replacement therapy and what type of hormone replacement therapy actually increases the risk of breast cancer. So combined hormone replacement therapy with estrogen and progesterone does increase the risk of developing breast cancer, but the increase in risk is moderate and not significant. And actually, there are some lifestyle risk factors that have a higher increase in risk than hormone replacement therapy. Estrogen-only hormone replacement therapy does increase the risk of developing breast cancer. And the increase actually continues even 10 years after stopping. So the combined hormone replacement therapy has a very minimal increase in risk. The estrogen-only therapy has a slightly higher increased risk of developing breast cancer. So women need to just be made aware of that. And obviously, everything has to be balanced, risks versus benefits. Some lifestyle factors. Lifestyle factors, these are obviously preventable risk factors. So these are actually the usual culprits that we always have with some cancers: smoking, obesity, and alcohol consumption. So smoking actually increases the risk of breast cancer by about 20%. So it is worth stopping smoking, and especially if they've smoked more than 10 years. So that increases the risk. If you smoked more than 30 years, then that even increases the risk even more. And it also increases significantly with the number of cigarettes that you smoke in a day. Obesity increases the risk of developing breast cancer by about 30%. And alcohol consumption also increases the risk of developing breast cancer, and this is by about 15%. So these are some lifestyle factors that, for cancer prevention, you can talk to your patients about to make sure that these are factors that can actually be prevented and can be influenced before screening and before early detection even. So really the message is that screening and awareness of breast cancer, the risk factors, and the fact that it is a disease that can be treated and prevented is key. So this is where our role as gynecologists comes in, to inform, to raise awareness, and to educate the patients, but also the relatives, and so that this information gets taken forward, and to obviously attend the screening program. Because indeed, early detection does save lives. And so this was a quick overview of breast cancer screening in Germany, and I'm very excited to hear about your experiences in Saudi Arabia. I just want to, at the very end, bring your attention to the PARSGO organization, of which Dr. Sara is also a member. It's the Pan-Arabian Research Society of Gynecological Oncology, and we are on social media, we're on LinkedIn and Instagram, and if you yourself want to be more involved in it, then please register with us and follow us, and also for more educational opportunities. Thank you very much.
Thank you very much, Dr. Sara. It was extremely good and excellent presentation. I would like to just tell you small information about screening program in Saudi Arabia.
Yes.
Actually, we don't have a structured screening program for breast cancer or cervical cancer. What we have an individual efforts. Some of the physicians, they are strict follow up with their patient. They dig in the history. During the month of October, which is a breast cancer month, yes, we have big awareness campaign. We have the trucks go all over the area and do the mammogram test. And even we have here in Eastern Province, we have a center called Mail Jabbar. It is like a charity institution. They offer mammogram tests for the patient who are interested to do the mammogram screening test. But as a program or as a structured program all over the area, where the family physician can refer the patient when she reaches to the 40, or if she has a strong family history, to send her for mammogram, not yet. We are in the way of planning this program. Actually, I'm assistant of care lead in E1 cluster, which is the cluster collecting all the hospital belong to Ministry of Health. I'm in charge of safe birth in that cluster. So we are planning to do a screening program for breast cancer. I hope it's going to be implemented soon. For pap smear test or cervical cancer screening program, actually we don't have it. That's why I'm not convinced with the crude incidence number that the institution gave us regarding 2.2 and the mortality rate 1.1. At the same time, I don't want to be a bias because I'm a gynecologist. I'm seeing a lot of cancer patients, so maybe for me it's high, so I don't know. And we are hoping to implement the screening program, and at least in the Eastern Province, then we can apply it at the national level.
Yes, it's very interesting. I mean, obviously, even in Germany in 2002, when the breast cancer screening program was introduced, there was always controversies, and there's unfortunately not just the gynecologists involved, but also the health ministry, the politicians, and that always makes things more complicated, and you have to have a lot of factors involved in this. I mean, in Germany, we also have a screening program for cervical cancer, which is not centralized actually, so they don't all go to one center compared to the breast cancer. So every gynecologist offers their own screening, but we do have a screening program, so we offer the yearly pap smear. The incidence, as you said, it seems quite low, the figures that you gave. But again, I'm also a gynecologist, so I might be biased. I know that in Germany, obviously Germany has a high population. The incidence is about 9, and the mortality is about 2. So,
do you have a vaccine offered by the government?
Yes, we do since January 2020, so just a few months ago, we have the Gardasil, the non-valent vaccine, which is now also offered for boys. So we have all the girls get vaccinated from 9 to 14 years of age, so earlier, and the boys as well, 9 to 14 years of age. And then there's the catch-up phase up until 18 years. And this is now officially offered by the government, yes.
For us, we don't have it. It's not sponsored by the government because the debate that it's too expensive and we don't have high incidence and prevalence of cervical cancer. Why I have to give it? Number 2, it's the acceptance of the society or the culture that to give my daughter or my son a vaccine for sexually transmitted disease, which is I'm not expecting as a mother, as a father. So still we have this big 2 issue, but I think we are working on proving that we have good prevalence of cervical cancer. Maybe one day we can have the vaccine covered by the government, not just in the private sector.
Yeah. What would be interesting, Dr. Sarah, to know, what do you feel the barriers are? I mean, you're obviously very involved in setting up the screening programs. What do you feel the main barriers are for the screening program? Is it cost effectiveness? Is it maybe population acceptance, like you said? What do you think are the main barriers?
Regarding the pap smear, I think the awareness at the level of the community, at the same level at the level of the healthcare provider. Because nobody, we don't have a campaign, to be honest with you. We don't have enough campaign and awareness campaign. Just last year, we started as a group in King Fahd Specialist Hospital to advocate about different type of cancer. And we are hoping to do more, but with the corona issue, we stopped. But I think lack of awareness at the level of the culture, the society, and the healthcare provider, it's the big barrier to start or to enhance or to encourage the patient to go for pap smear tests.
And both the pap smear test and the breast screening, they're done by gynecologists?
No, for the gynecology, we do just the pap smear, and even pap smear, it can be done by general physician or family physician. It's not mandatory to be gynecologist or gynecologist. It's just simple test. For mammogram, majority of gynecologists in Saudi Arabia, they were trained in Canada. So in Canada, we don't have breast cancer as a part of gynecology cancer. So we have our breast surgeon and a group, at least in Eastern Province in my hospital. And regarding I have a few questions before we start with the participant. Regarding at the level of the Eastern Province, I don't know what's the incidence of BRCA mutation in breast and ovarian cancer, but we have a figure from our cancer registry that's around 17 to 20% in Eastern Province area. And my other questions that American Cancer Society, they don't recommend any more self-examination. So what's your point of view regarding this?
Yeah, well, in Europe, we still very much recommend it. I know that in the States, they don't recommend it because it leads to more anxiety, and actually there's no hard evidence that self-examination improves or reduces the mortality rate or improves early detection. And to that, I agree. There is no hard evidence. However, we always feel that the women do need to know what their breasts look like and what their breasts feel like so that they can actually pick up any changes. So in Europe, it's still recommended.
Okay. So we can go to the question now.
Yes, absolutely. Shall I open?
Okay. First question. I don't know. We have around 27 questions. I will try to cover a majority of them as much as we can. For smoking, does it apply for passive one? For my point of view, no. What do you think, Dr. Sarah?
There is no evidence that I've come across that passive smoking increases the risk of breast cancer. It's the active smoking.
Exactly. So the second question for you, Dr. Sarah, what's the reason of a bloody discharge from the nipple during the third trimester of pregnancy or after delivery, and how it can be treated?
So in terms of bloody discharge, generally if they're breastfeeding, then that's nothing to be too worried about, but bloody discharge should always be looked into. So it should always have a breast examination, to be honest with you. So it probably won't be anything major. It could be a small polyp or anything under the mammary gland, but it should be looked into.
Okay. Some of the questions we answered them during the presentation, so I'm not going to repeat them. If breast cancer is not hereditary, what are the causes?
Sorry.
If a breast cancer is not hereditary, what are the causes, the other causes?
Yes. So most breast cancers are not hereditary, as you said, about 95% are not hereditary. And then there is random mutations. So random mutations of the breast tissue, which causes them to become cancerous. And this can be included, for example, this is where the risk factors come into play. So lifestyle risk factors, race, ethnicity, hormone replacement therapy. And sometimes women get breast cancer and have no risk factors. So there's a random mutation.
There is a question how we can tackle this problem with the huge pandemic, COVID-19 being faced by the world. Do you mean the problem of screening, or I don't know the question specifically. If it's regarding the screening, as we mentioned, the breast cancer screening in Europe every 2 years, and United States, the recommendation annually for pap smear every 3 years. If you have a disease, cancer, you have to be treated. For us in here, we accept the patient in King Fahd Specialist Hospital, which is the only cancer center in Eastern Province. What about your side, Dr. Sarah?
So the question relates to the corona pandemic at the moment.
Yes, exactly.
Yeah. So yes, the same here. So cancer is seen as something that needs to be continued to be treated. Women were also still encouraged to attend their screening. So even their pap smears and such with the appropriate protection, but all cancer patients were still treated.
Okay. What about ultrasound complementary exam to mammogram? Would you recommend it to be done all the time, first times of a screening, or only if there is some suspicion?
So if there is a suspicion in the mammogram, you should always do an ultrasound for the breast as well. Correct. If the patient is between 50 and 69, then there's no need to do an additional ultrasound examination if the mammogram is normal. If the patient is under the age of 50, and particularly under the age of 40, sometimes they have dense breast tissue because they're younger. So the mammogram might not pick up everything. So then you can use the ultrasound scan as an additional image. So it's more of an individual case-based decision.
What's the role of breastfeeding in reducing breast cancer incidence?
Sorry?
The role of breastfeeding in reducing breast cancer incidence.
So there are sometimes studies that say that it actually reduces the risk of breast cancer, but there is no hardcore evidence to that. So it's similar to other lifestyle risk factors. There's no hardcore evidence, but there is an evidence that it reduces it.
Okay.
And so we should encourage it anyway. So breastfeeding is always encouraged.
Okay. Okay, the patient diagnosed with breast cancer and she used Mirena. It is a contraindication or use implant. It is a contraindication or relative contraindication.
It depends, because not all breast cancer is the same. So it depends on what the hormone receptors were. Most breast cancers are hormone receptor positive, generally estrogen receptor positive, and also progesterone receptor positive. So we would generally stay away from any hormonal contraceptive after the diagnosis, but it depends on the type of tumor. It's not a general contraindication to an IUD, because you can still have the copper IUD, for example, the non-hormonal, but we would stay away from the hormonal.
What do you think about the BRCA1 positive? Usually they are triple negative. It's safe to yes. Put the Mirena? Actually, yes. I read one article debating this issue, but they did not reach to final conclusion to say, yes, it's safe, go ahead. For me, I would be more cautious, even if she's triple negative, because you never know. I don't know. I'm not expert.
You never know, and obviously she still has the risk that she will develop breast cancer in the contralateral breast, for example. That's still a risk factor. For me, it's about patient, so talking to the patient and telling her that this could be a risk factor. And, you know, if she's had triple negative and she really wants the Mirena, then you can say to her, okay, but we have to monitor. She will be in the intensified screening program in Germany, at least. So you would just monitor her more closely with the knowledge that, you know, there could be a small risk, even though, again, we're not so sure from the evidence.
Yeah. There is one question, the relationship between stress and cancer. From my point of view, actually what we are reaching to as a conclusion now, we are in an era of the immune system function to fight the cancer. So it's well known that the stress can decrease the immune system. It is fundamental or it's the main cause of cancer? No, but it can be one of the co-factors. What do you think, Dr. Sarah?
I agree with you completely. So there are many studies that show that stress is one of the major factors that can contribute to the, you know, to cancer development. It's not linked, like you said, as a causal effect yet, but it definitely contributes to it. And also, and more importantly, perhaps, is it also affects the healing process and how quickly you heal from an operation or from chemotherapy and so on. And there's been studies that have actually shown that. Yeah.
Exactly. Regarding one of the questions said guidelines have changed, Dr. Sarah, she talked about the guideline in Europe, not in the United States, which is completely, there is a big difference between the guideline in Europe regarding the breast cancer screening, modality, the time, and when to start. So just replying to Khan, I think. Okay, the
so
question,
that was the German guideline, correct?
Yes.
That was definitely the German guideline.
Yeah, I mentioned this question because I want to emphasize that it is a purely German guideline, and this is what we mentioned in our poster, that it's an update between Saudi Arabia and Germany. Regarding the obstacle of breast cancer screening program in Saudi Arabia, we don't have obstacle. We need to make a clear plan and we need to calculate our budget, and we need to move forward, and we are doing our job, at least in Eastern Province. Regarding, okay. If a patient has high risk of genetic screening, can I do mastectomy as a preventive breast cancer?
Yes, you can, especially if they're high risk. You can discuss with them, always discuss with the patient, because obviously mastectomy is a very radical procedure and does actually reduce the risk of developing breast cancer if you do a mastectomy by about 95%. So why it's not 100%? Because even with a radical mastectomy, you cannot remove all of the breast tissue. There will always be some small breast tissues left behind, regardless of how well you operate in a mastectomy. But you can obviously reduce the risk massively. Bearing in mind that obviously if you are in a country such as Germany, where there is a very organized and good early detection program, most women may not need a mastectomy, they just need the regular follow-up or may not want it, because a mastectomy obviously has big psychological impact, but it's definitely an option that we always discuss with our women. And some women say straight away, no, I want a mastectomy, and then that's performed.
Yeah, which is we don't have it. Even if she's a BRCA positive, sometimes I try to convince them to do prophylaxis oophorectomy, even she's 40 years old. They are reluctant.
They're reluctant.
Yeah.
It's a difficult subject because obviously
Exactly.
you also then have the side effects of estrogen deficiency, osteoporosis in the long term, and fertility issues, obviously.
Exactly.
But quality of life versus length of life in that sense. Then,
yeah. What roles can general and family physician in prevention and screening of breast cancer, cervical cancer currently in Saudi Arabia? It is an individual effort. It's not structured. Some of family physician and general physician, they do their best in history taking, breast examination, and even pap smear. And when they detect abnormality, they send the patient, but it's not a guideline for BHCs for the time being, but hoping for the best, inshallah, in the future. Okay.
So I have a question here. I don't know if that's been answered or not. The role of vaccine in males aged between 9 to 26 years old. Just because you also asked me about this, Dr. Sara, it's so in Germany, we've started vaccinating males from the age of 9 to 14, and it's actually extremely promising. The first data we have is that it reduces the incidence of pre-invasive cancer lesions by about 40%. So there's definitely a role, but obviously we're still awaiting long-term follow-up and data.
Exactly. Just to mention that HPV vaccine, its maximum, if I will be generous, it was started 14 years ago. So if you notice that when they started the age of immunization earlier, up to 26, because as I mentioned, that is the peak of the immune system function. Then they extend the age. So still we need to wait for further study to prove how long the immunity will stay in the body, it's long lasting, or notes need to be reposted. So boosted, still we need to wait for this result. But for the time being, the vaccines can be given early, and I'm very happy about the FDA approval for Gardasil 9 and adding and extending the age to 45. So at least you can, for my culture or my community, to convince them, please, if you have the access to vaccine, take it. Why early marriage is considered a risk factor for cervical cancer in Eastern country, although it's sometimes with single partner? Because, as a general knowledge, if you have early marriage, you have more exposure to the risk of infection, and the parity also can play a role in developing cervical cancer. I did not mention it, but it was mentioned in one of the references. So yeah, I think this is one of the explanation. Is there any herbal or alternative treatment or prevention of breast cancer?
For prevention?
Yeah, herbal.
Sorry, I didn't get that.
Any herbal intervention?
Herbal interventions. So To be honest, there is quite a lot on the market that you would probably see if you go on the internet, that there's some herbal things. Green tea has been known to have positive effects in preventing because of antioxidants, as well as some leafy vegetables and fruits. Broccoli has also known, but all of this is not evidence-based, so I can't back it up with evidence. But what I tell my patients, a lot of my patients like to go for herbal alternatives or also have some herbal medicine parallel to their treatment. And I say, as long as it doesn't interact with anything and doesn't do any harm, then I always encourage them. And there is some evidence, but nothing that we can back up scientifically as of yet. And so far, the only things that look promising are green tea and broccoli. I don't know if you have any experience with that.
For me, I don't advise my patient to take any herbal medication. Because I don't know from where they bring it, how it is sterilized. I don't know how they are going to use it. To be honest with you, for my patient, I tell them that, listen, if you want to use it, it's your responsibility, but I don't advise to use it, because I don't know, sometimes it has its own component that we don't know about it. It can enhance the growth of the tumor. So for that reason,
that's the disadvantage of it, that there's no regulation for it.
Okay. There is a question: what's the relation between gynecomastia and breast cancer in male?
So gynecomastia means that the breasts are bigger, so increased fat and breast tissue, which also increases estrogen exposure. And that indirectly then increases the risk of breast cancer. However, most male breast cancers are genetic. So there's no real causal relationship between that.
Okay. Does cervical cancer affect the fetus and childbirth, and what's the impact? Actually, it depends on your question. Do you ask during a pregnancy or pre-pregnancy? And it depends on the stage. It depends on the modality of treatment. So it's long answer. It's need to be specific. If it's an early stage, we can do trachelectomy and cerculage, and she can get pregnant. But if she has the cervical cancer during pregnancy, it depends on the gestational age and which stage she's on. So it's beyond this lecture to answer this question.
There's a question, if you permit, just about the X-ray and the safety of it, because I mentioned it in my presentation. So the X-ray radiation exposure with the mammogram is extremely low. So that is not a safety concern. So radiation, the unit that radiation is measured in is MSV. And a normal person that walks around normally is exposed in a year to about 3 MSVs. So 3 of these radiation just from the natural surrounding living in this world. And the MSVs that you get exposed to during a mammogram are 0.4. So it's extremely low. So it's safe.
Okay. What else? I think we answered the majority of the questions. Regarding the vaccine, even if you don't have a risk factor, if you have the chance to have the vaccine, do it. It's like one of the basic vaccine that we are taking in early childhood.
Absolutely. I agree with you. I mean, a vaccine is not a treatment. It's a prevention. So for healthy people. So you don't need to have any risk factors. You don't need to have any criteria apart from obviously the age for which this vaccine needs to be given. So definitely,
Yeah, the last questions. there is a person asked, when does the patient with HPV infection can get pregnant? It depends on the lesion that she has. If she has ascus with HPV, she needs to do colposcopy, and it depends on the anomaly that she has. But for me, I'm assuming that she's HPV and she has high grade. So if she's my patient, I will do the intervention with the cone or lead. Then at least I need to have 2 pap smear negative to make sure that she's cleared up. Then I will allow her to get pregnant. What do you think, Dr. Sarah?
Yes, I mean, it depends on the lesion, obviously. If she has a lesion, then it's better to treat it first and then to go for pregnancy. In Germany, you do a pap smear. If you want a planned pregnancy, you make sure that your pap smear is up to date and your HPV test is up to date before you go ahead. But obviously, some pregnancies are unplanned. And if there is a lesion, then you would treat the lesion first. Yeah.
Yeah. I think we covered the majority of the questions, and thank you very much for the attendees, and thank you very much for Tرووب event for organization this event, and thank you very much, Dr. Sarah, for the time that you gave us. I know you are overwhelmed, but thank you very much for giving us the opportunity to exchange our experience with Germany and learn from your experience.
Thank you so much for inviting me, and thank you for the exchange.